Good morning. Before I begin, I would like to thank the Society for allowing me this opportunity to share our work. My name is Mark Mahan, a fourth-year general surgery resident at Geisinger in Northeast Pennsylvania. Today I'll be virtually presenting emergency department overutilization following cholecystectomy and inguinal hernia repair. We have no financial disclosures. Emergency department overutilization has become an immense strain on the current healthcare system from patients to providers alike, with significant financial implication. It is estimated that inefficient ED usage is responsible for nearly $38 billion in annual wasteful spending, while nearly 56% of this is described to be avoidable. Use of the ED, however, continues to grow by over 13% from 2005 to 2013. This is hypothesized to be due to the lack of established care and limited clinical access. Despite these staggering numbers, there remains little known with regards to emergency department utilization following elective surgical procedures. Two of the most common procedures performed across the United States include cholecystectomies and inguinal hernia repairs. Both procedures performed over 700,000 times annually. These surgeries are often cited as bread and butter cases, requiring no specialized training or fellowship, and may even be performed by yours truly. Dr. Dana Tellem, while at Stony Brook University, used a New York State registry to examine the 30-day ED return rate following cholecystectomy, appendectomy, and inguinal hernia repairs from 2005 to 2014, finding a postoperative ED return rate of 7.9%. This is clearly significant if what is publicly perceived as a simple operation leads to an unnecessary emergency room visit. If this is true, why is it happening? And more importantly, is there an explanation or solution for it? In a world of healthcare searching for cost reduction, is this a simple piece to help improve an already strained financial system? With this in mind, our primary outcomes following elective cholecystectomy and inguinal hernia repair were to define the number of patients that return to the ED at least once, how many of these patients were admit, how many of these returns were related to their surgery, and how many were preventable. Therefore, we performed a retrospective review of elective cholecystectomy and inguinal hernia repairs from January 2018 to June of 2019, and a review of the prospectively held Geisinger ED utilization database, which includes 8 hospitals in a single healthcare system. Patients younger than 18 years of age or those with an admission status as inpatient were excluded. Patients who returned to the ED within 30 and 90 days were analyzed for hospital readmission, cost of ED visit, and prevalence of ED visit by day and time. Charts were directly reviewed to delineate preventability, relation to the index surgery, and clinician communication within 48 hours of their presentation. It's important to be clear that we only looked at the initial visits and not repeated ED visits amongst this population. The definitions of related and preventability were defined based upon the Goldfield criteria as published in the Healthcare Finance Review. Over this year-and-a-half period, we identified over 3,600 patients that underwent elective cholecystectomy and inguinal hernia repairs. Approximately 8% of these patients returned to the ED within 30 days of surgery and 13% at 90 days. In the immediate postoperative period, nearly 68% of visits were related to the index surgery, and impressively 58% were deemed preventable. As expected, over a longer time frame, those visits became less frequently related to their surgery and less preventable. It is key to point out that regardless of the postoperative period, over 75% of these patients who returned to the ED did not require hospital admission. When broken down by generalized procedure, we know an increased return rate following cholecystectomy compared to inguinal hernia repair. While those following inguinal hernia repair had an ED diagnosis more likely to be related to their index operation and more likely to be preventable. Again, we see the overall percentage of return visits, those related to surgery, and preventability to be reduced in the late postoperative period compared to the early postoperative period. We as well saw that while more patients are sent home in the late postoperative period following cholecystectomy, there was a slight increase in hospital admission during the late postoperative period following inguinal hernia repairs. Secondary outcomes revealed that the most prevalent days of patient return were Monday through Friday, accounting for over 74% of patients, while Saturday and Sunday were surprisingly 2 of the least utilized days. Just over half of our patients returned during typical business hours from 8 a.m. to 5 p.m. when we would expect clinic to be open. The average cost of ED utilization per visit was just over $974, and during review of the 90-day postoperative return period, initial ED visit was found to be an average on the 27th postoperative day. Surprisingly, only 1/3 of patients that returned to the ED communicated to our staff within 48 hours prior to their presentation. Limitations of any post-acute care study is the inability to catch returns outside of the primary system. Secondly, although the published Goldfield criteria are used for hospital readmissions, we feel this criteria is transferable to ED visits in terms of whether the visit was related to the index operation and whether it was preventable, and therefore elected to use it for our study. Lastly, it is again important to note that this study only reviewed the initial ED presentation and did not account for the multiple return visits several of our patients made. So what does this mean for our bread and butter cases, where patients anticipate same-day surgery and an early return to normal life? Based upon utilization trends in the United States, with our model, you can derive an impressive annual expense of over $204 million. If you take this one step further and consider 41% of these cases were deemed preventable, this is more than $83 million in preventable, unnecessary expense to our health system. Again, quite impressive considering this only accounts for the initial ED visit and does not include the numerous visits we know to call our frequent flyers. So where do we begin in correcting this deficit? I go back to our definition of preventable. We must improve discharge planning, appropriate outpatient follow-up, and improve overall coordination amongst teams. This first begins with setting appropriate expectations to our patients and ultimately boils down to improved communication. Moving forward, with the benefit of this data system, we have the ability to delve into specific charts and highlight the demographics and comorbidities of patients that not only return to the ED, but have deemed preventable visits. Future studies plan to identify traits of these preventable visits to help to answer if there is a select population that warrant greater communication or emphasis in discharge planning. Likewise, we plan to implement increased patient communication in the form of home calls throughout the postoperative period that extends to the 28th postoperative day. If only 1/3 of our patients communicate to us within 48 hours of their presentation, are we as accessible to them as we really should be? Overall, we identify the opportunity to reduce an improper use of significant resources and improve healthcare delivery. Thank you, and please stay safe.